Hello, everyone. My name is Emily Cossack, and I'm the Knowledge Manager for the Canadian Institute for Public Safety Research and Treatment. I want to welcome you to today's session, which is the Depression Crash Course. Before we get started today, here are just a few housekeeping items that I want to go through. First of all of you are in listen-only mode. That's to limit feedback and noise during the presentation. Just so you know, today's session is being recorded. You'll be sent a copy tomorrow, so if you miss anything, you can watch it again. The GoToWebinar launch window can be blocked by some organizations, so if you're having trouble hearing or seeing us, you may have to join us by phone. Lastly, we will be looking for audience questions at the end of the session, so please send us your questions through the questions box or be ready to raise your hand to ask your question in person. Now, I'm very pleased to introduce our speaker for today. Dr. Vivien Lee is the Chief Psychologist and Bureau Commander of the Healthy Workplace Team for the Ontario Provincial Police Service, She's also, among her many other accomplishments, a clinical advisor for Boots on the Ground and Toronto's Beyond the Blue. So thank you so much for being here today with us, Dr. Lee. I'm going to go ahead and give sharing screen control to you. Just one moment here. There you go.
Great. Am I showing the right screen?
You are.
Okay, awesome. Thank you. Good afternoon or good morning, depending on where you are. So as I mentioned, my name is Vivian. I am a psychologist. I've been practicing in Ontario for about 12 years or so. I am the Chief Psychologist for the Ontario Provincial Police, so the OPP, although I'm not speaking on behalf of the OPP today, I just wanted to make that clear. So a bit about my background. I've been working clinically with first responders in the military for about 12 years now. I spent a number of years working in a trauma program at the Centre for Addiction Mental Health in Toronto, and we saw many individuals who were referred through our workers' comp, WSIB, and we saw many first responders. And everyone has such a unique individual story, but we would hear the same kind of experience over and over, and you start to hear some of these similarities between the different public safety types of organizations. So I'm pleased to be invited here today to speak about depression, just to clarify a little bit about what clinical depression is and what it is not, and the public safety stressors that can contribute to the onset of depression. All right, so just a bit of an outline. What is depression? Contributing PSP stressors, behavioral changes you might notice in yourself or in your colleagues. What are some of the treatment out there? And given my role with the OPP, I'm going to recommend, so hopefully there's some supervisors and managers on here as well. I wanted to just recommend a few things for organizations to consider. Okay, so let's start with what is depression. And everyone has an idea of what depression looks like. And I think especially for public safety personnel, when you're responding to someone, when you go to a call and someone is having a mental health issue, it's not usually that they're feeling a little bit sad. And then when you show up, it's often someone in crisis. So we tend to think of some of the extremes when it comes to mental health and depression. Right? So often we hear depression, we think of someone who's very sad all the time, who has trouble getting out of bed, who's tearful a lot and has trouble controlling their emotions. And that's certainly what severe depression can look like, but it can also look very different. I often hear, well, I didn't think I could be depressed because I'm still functioning okay, or I had no idea that person was depressed because they seemed fine. Right? And so much of the time, especially when there's kind of gradual onset of symptoms, it's really hard to tell from the outside when someone is experiencing depression. So it may look like someone who can't get out of bed and who's very tearful a lot, but of course it can look like someone who's still going about trying to do their daily things and even having fun once in a while. So let's talk about first what isn't depression. So we hear depression a lot in day-to-day language, oh, I'm so depressed, because something happened. And so I do think the word might be overused when it comes to the clinical definition of it. So what I did want to emphasize is that clinical depression is not sadness that is proportional in response to an event. Right? So if I have a long-term relationship breakup, or I get laid off and I have to worry a lot about my finances, I'm going to feel sad, and that's going to be a very natural and proportional response to the situation. If I lose someone close to me, or I lose something, I lose my house, for example, I might be grieving. I might have bereavement over this loss. And I certainly might feel sad for a while. I might feel kind of numb. I might feel a little energy. And this is a normal, natural response to this kind of situation. So I did want to emphasize that, I think we tend to jump to the word depression when there's a very understandable stressor for it. And I've heard stories of someone loses a loved one, their loved one dies, and they go to their family doctor, and very well intentioned, they want to help with their distress, and they prescribe antidepressants. And that just makes me a little bit uncomfortable, because someone, when they're experiencing a major loss, it doesn't feel good, but it's something that people have to work through in order to process it and be able to move forward. So when I'm talking about clinical depression, I'm talking about major depressive disorder. So that's a technical name, MDD, in basically the mental health Bible for psychologists and psychiatrists, the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. And for any diagnosis in the DSM, what's important to remember is that it's causing clinically significant distress or impairment. And so that may sound obvious, but I think we tend to, sometimes we over-pathologize again, and we might diagnose someone, you hear someone say, oh, I'm so OCD, and it's really not causing any distress or impairment. They just like things in a certain way. So when we're talking about MDD, we're talking about a minimum 2-week period of certain symptoms. So at least one of these symptoms is a depressed mood, or it could be both, or markedly diminished interest or pleasure in all or almost all activities that someone normally enjoys, right? This is called anhedonia. And this is something where I've noticed individuals sometimes they're quite surprised that they're diagnosed with depression, because they aren't necessarily being sad a lot. They describe feeling numb a lot. They just they're not interested, they don't get pleasure out of things that they used to. So you need one, a depressed mood, or the markedly diminished interest or pleasure. And very importantly, you're experiencing this most of the day, nearly every day. We're all going to have periods of times. We're all going to have a down day or two where we're not really interested in much. We're just having one of those days. So that doesn't mean depression. So this is at least 2 weeks or longer. And then in terms of the other symptoms, you need at least 4 of any of these symptoms here, things like changes in appetite, major sleep problems, psychomotor agitations, so basically feeling very fidgety or restless a lot, or just slowing, having this fatigue, loss of energy. And I mean significant. I've heard people describe it as, when you're in a swimming pool and you're trying to walk, but it takes so much more effort, that kind of psychomotor slowing, right? Things just take a lot more energy. Feelings of worthlessness or excessive or inappropriate guilt. So kind of beating yourself up over and over and over for something that wasn't totally in your control, or it's just really out of proportion. Having trouble thinking or concentrating, or really having trouble making simple everyday decisions. What should I wear today? What should I pick up for dinner? These kinds of simple everyday decisions. And recurrent thoughts of death, recurrent suicidal ideation or attempts, or a specific plan. So noting again that except for the last one about suicidal ideation, this is nearly all day, every day for these symptoms as well. So it's significantly upsetting you, or it's causing a lot of difficulty just getting your stuff done day to day, work, personal life, things that you need to get done. I did also want to specify as well, going back to MDD, clinicians will often give a specifier, right? Mild, moderate, or severe. And I do see some misinterpretation sometimes when someone has a diagnosis of depression, mild, because they think, oh, you're saying it's not serious. This is just in the name of it, because remember, for a diagnosis, you need clinically significant distress or impairment. So even a mild diagnosis of major depressive disorder is saying that this is very significantly impairing or distressing the individual. And then when it comes to depression, so I personally am very conservative with my diagnosis. So what does that mean is I don't like to pile on diagnoses if they're accounted for, if symptoms are accounted for by one thing. So you can get a diagnosis of major depressive disorder with anxious distress, because there's a lot of overlap with depression and anxiety. You often see someone kind of ruminating, thinking about the same things over and over and over. And with depression is often in the past. Why did I do this? I shouldn't have said that. I should have done this. With anxiety, kind of ruminating again over the same kinds of things, but it's more forward thinking. What if this happens? What if something bad happens? You know, what if I don't get better? What if I fail? So you do see quite a bit of overlap with depression and anxiety. So it can be kind of tricky to tease apart sometimes. So you can certainly have a diagnosis of depression with anxious distress. But then there's also other diagnoses that have a lot of overlapping symptoms. The generalized anxiety disorder is where it's causing major distress or impairment. Someone's kind of worrying about something bad that might happen. Panic disorder, or someone's having unexpected panic attacks. PTSD, which I'm not going to get into, but there's certainly a lot of overlap as well. So just some things to consider. Really, I look at, when did each one start? How would I treat these? Do I think the depression is in response to someone having developed PTSD and then all the impairment that comes along with that? And if we treat the PTSD, will the depression lift? So I look at those kinds of things when I'm talking about the different diagnoses. And of course, it's always good to go to the family doctor and get a checkup, because we want to look at, is there a medical condition causing this? Right? Hypothyroidism, low thyroid functioning, of course, can result in symptoms that look a lot like depression. Substance misuse. If I'm abusing cocaine and then every time I go through these withdrawals and I have a lot of these depressive symptoms, is that what's causing my mood? So ruling out some of the other conditions is really important as well, to know how to appropriately treat this. Okay. So I just wanted to highlight this. This is from a study in 2017 by Nick Carlton and al., who I'm sure you know from CPSR. And there's different estimates of depression out there in the general population, in subpopulations, et cetera. So it can be difficult at times to get a definitive number, especially if you're going more specialized into the public safety personnel. So I wanted to highlight this snapshot. So this survey went out to all public safety organizations across Canada, and it was voluntary. So it's basically, hey, there's a survey. If you're willing, please go online and answer all these questions. It's self-report questions. So keeping in mind that this is not entirely a representative sample, because it's people who chose to volunteer and participate in the survey. So what I've highlighted here is that major depressive disorder symptoms. So this is not diagnoses. So these are someone rating, how often or if they've experienced MDD symptoms, depressive symptoms. And so again, not diagnoses, but these are individuals who scored above the clinical level of depression symptoms in the past couple of weeks. So looking across, you can see the breakdown of the different public safety groups. Overall, 26.4% of the people who responded rated at a clinical level of depressive symptoms in the past couple of weeks. And if you go across, it fluctuates, but you can see a high, for example, in call center operators and dispatchers at 33.2%. So basically, 1 in 3 who responded scored at or above the clinical level for depression symptoms. So you can see kind of varying across the different populations. So you can see at a given time, the reported depressive symptoms are quite high. So if you just think about your specific workplace and how many people work there, and then think about, hey, it's 1/3 or 1/5 of the people around me are experiencing these kinds of symptoms. So this takes me into more, I think, contributing stressors that are a little more unique to public safety professions. You might have heard about some of these in the past, so I'll just kind of quickly go over some of them as a review. Moral injuries. So basically, it's inevitable in any kind of helping profession. So injury to your morals, what you hold as good and bad, right and wrong in your values. So most of us, when we're small, when we're little, we grow up with what's called a just world idea. But there's justice in the world, right? So good things happen to good people, bad things happen to bad people. So if I do good things, then good things should happen. And of course, we all grow up at some point and we realize, well, the world's not actually like that. And in helping professions and public safety professions, this is on the regular. This is basically the bread and butter, right? Because people are often calling 911 or they're in jail because something bad has happened or they've done something bad. So we see violations of this just world idea on a very regular basis, right? So what a first responder, emergency responder may see, in one set of shifts may be more than the general population sees in a year, for example. So just some examples that I've heard about quite a bit. So it could be something more relatively mundane and day-to-day as attending the scene of a motor vehicle collision and an impaired driver causes crash, and now there's like serious injuries to the family that was hit by them, and they're just fine, right? So seeing all this damage done to a family just out for a normal drive. Pediatric VSAs, vital signs absence, because really children are not supposed to die. So this feels, this can be very difficult for many people. Again, something a little more day-to-day, but that I've seen, I hear about a lot, kind of is wearing people down. Attending the same house over and over and over for the same domestic calls. And maybe you're trying to help the abused person and they're not in a place, they're not ready for your help, or they actively, argue against you. And you know that one day this person may be carried out in a body bag and you're trying to help them, they're not taking your help, they're not ready for it. And just can create this, what's the point feeling. And some of the kind of more obvious moral injuries is causing harm to someone for resuscitation, right? So perhaps performing CPR on a frail elderly person, that causes obviously a lot of physical damage, or having an officer having to use his firearm for his or her own safety, their partner's safety, or for the safety of the general public, and injuring or sometimes taking a life during those actions. Understandable, procedurally, it makes sense, but that can be difficult. That can be a big, hard pill to swallow for some people. So there's moral injuries, and then there's compassion fatigue. Although I'll start with compassion satisfaction. So how I personally envision compassion in a helping profession is it's like carrying a big sponge. And every time I'm around the suffering of others, right? Someone's been robbed, someone had a loved one die, someone's been badly injured in an accident, or lost all their belongings in a fire, right? So every time you're around that, you're kind of absorbing some suffering from other people. So it's kind of like a drop in the sponge, right? So just drop, drop, drop. And why on earth do we subject ourselves to this kind of thing? Because it feels really good to help people. I don't know, for all the public safety personnel in here, I don't know why each of you went into your profession. I'm going to assume that at least part of it was because you like to help people, because it feels really good. It's very meaningful. It's very rewarding. But of course, we can't help everyone, no matter what we do and how hard we try. Even if you go above and beyond on a call and you can show compassion to that parent who just lost their child, you can't take away that suffering. You can make the situation in the moment maybe a little bit easier for them, but you can't take it away, right? So throughout your career, what I've seen quite a bit is this kind of cumulative effect, right? So it's like that sponge, every call or every case where, I'm around, people who are suffering, it's like a drop of water and another drop of water. And if I'm not bringing out the sponge on a regular basis, whether it's processing it, talking about it, engaging every day in self-care, what can happen at some point? The sponge gets full and it can't absorb anymore. So here's another type of injury, like moral injury and compassion fatigue, that can contribute to mental health difficulties over time in public safety personnel, including depression. So those are some of the operational stressors, right? So stressors as a result of your duties, the duties of your day-to-day job. And of course, we all work in organizations and there's unique stressors to each organization. So certainly what many of them have in common is shift work. Shift work is very difficult physically for the human body, especially unfortunately as we get older, we don't bounce back as easily. If we're not sleeping, we're not resting enough, then we're certainly not recuperating. This is not good for our resilience. Things that are outside of our individual control, staffing, are there enough staff? Are we chronically short-staffed? Do I constantly have to go to more calls than I normally would? Am I not getting any downtime? Equipment, do I not have the appropriate equipment? Is it constantly breaking down? That's a stressor. In PSP professions, there's often this high level of responsibility for your job, right? So in your specific duties, often if you go to a call, for example, if you make a mistake and something goes wrong, all eyes are going to be on you, right? And sometimes their safety or life might be in your hands. So there's this high level of responsibility, especially if things go sideways. However, there's so much in the day-to-day shift that's outside of your control, right? So you have this high responsibility, low perceived control over your day-to-day. And that's a tough pill to swallow, because if you only have so much wiggle room, but then if something goes sideways, you're going to get in a lot of trouble and something very bad might happen to someone. That's a lot to balance on your shoulders day to day. And something I've seen quite a bit, and this can certainly contribute or worsen depression, PTSD, and any other mental health difficulty that someone's going through, is perceived injustice or an institutional betrayal. Some people call it sanctuary trauma. So in essence, you spend years, sometimes decades, dedicated to this profession, to your organization. You know, you have everyone's back, you cover for people when they're having a hard time, you just do your best and go above and beyond sometimes, and then maybe you're having a hard time. And you put your hand up and say, I gotta take a knee for a bit, or I just need a bit of leeway to, you know, do this thing to take care of something in my life. And the organization is like, oh, it sucks to be you, right? This can feel like a big punch in the gut, right? So there's this betrayal where I've done so much for this organization. I've sacrificed a lot. I've sacrificed my health and sometimes family for this organization. And now when I need you, after all that sacrifice, you're turning your back, right? And that can be very, very difficult for many people. So certainly this can compound difficulties that someone is having. And I did want to touch on as well burnout. So burnout is a little bit different in terms of, this is really usually a factor of the job and the role itself and any stressors there, right? So burnout is this prolonged response to chronic interpersonal stressors on the job. So what you see a lot is this emotional exhaustion, like I just can't cope with anything, I can't deal with this anymore. Cynicism, what's the point? Nothing's going to change, no one's going to get better. And low personal efficacy, right? So meaning that you feel that you don't have much control, you feel that you don't have much power to do things or get things done or make things better. And so often this becomes associated with feelings of hopelessness and difficulties in dealing with your job or doing your job effectively. And you know, we've heard a lot in the media in recent times about burnout. And the reason I really want to bring it up here is certainly we're seeing a lot of this, especially if you're very short-staffed in your job. For example, during COVID, you know, sometimes like total platoons or stations got wiped out and people had to isolate. So then, of course, there's a lot more work for everyone else. So this kind of burnout, this I had some concern that we're medicalizing burnout. So in terms of organizations, what am I talking about? So if you know, my organization, if my platoon is constantly short-staffed and people are just burnt out, they're just working too hard, they're not getting enough rest and recuperation, and they're having a hard time. And then I say to them, well, you might have depression, you should go to the doctor. What am I doing there? They might have depression, but really I'm turning an organizational shortfall into that person's medical problem. So I do like to highlight this because it's another example of things that are outside our individual control. But of course, if you go off and get better and then come back to the same job with no changes, this is going to be a risk again. So burnout is very often tied to organizational stressors, and those are things that need to be changed on an organizational level. Right, so we've talked about what depression is, what it isn't, some of the things in the public safety professions that may contribute to depression. So what is actually happening with depression? So there's so much great research out there, and I don't have the capacity to go through it all and summarize it, but certainly there's, you know, I think about 20, 30 years ago, serotonin and neurotransmitters, there was this big breakthrough, and you know, people were thinking, oh, it's because of this shortage of serotonin, for example. So of course, our brains and bodies are much more complicated than that. But there's neurochemical changes that can happen. So different types of neurotransmitters like serotonin, for example, neuroendocrine. So we know that we can have dysregulation of stress hormones if we're under a lot of stress, or we become depressed or experience anxiety issues. We can certainly see a relationship with immune system difficulties. And, there's been some preliminary interesting findings in terms of brain structure, right? Having less gray or white matter in people who have had depression for a while. So there's all kinds of research out there in terms of what are the different factors here. So bottom line, there's no one magic bullet. So there's a number of changes that can happen. And is it chicken or egg, right? So it's this physical thing causing my depressive symptoms, or has all these stressors and me developing depression caused all of these neurological and physical changes? Chicken and egg, right? But you certainly see when someone is under a lot of stress for a long time or they're feeling depressed, you see these changes over time. So it's not as simple as just snap out of it, right? Just think positive and think differently, because now you have these neurological and physical changes that have occurred, and it's working. If you go through psychotherapy, you can certainly see some positive improvements there, but it is more complex than it has been made out to be in past years. Okay, within yourself, what are some things that you may notice? Physical. Sleep problems, I hear the most, absolutely. So if normally you're sleeping okay and you're having trouble falling asleep or staying asleep, or you're waking up very, very early, or the opposite. Now you're sleeping like 12 hours and you just never feel rested, and you just feel like you need more and more sleep. So major changes in sleep, appetite disturbances, stomach upset, gastrointestinal distress, having urgent need to go to the bathroom a lot, for example, feeling tired more easily or often, feeling very fidgety or restless, slowed movement, kind of lethargic, kind of like what I was saying before, that example of trying to walk through water in a pool, like that kind of slowed movement. Some people will have more aches and pains and decreased libido. I hear that one quite a bit as well. So these are some physical changes that are often the first thing that people notice, because it's something that's a bit harder to ignore. Cognitively, and I'm focusing a bit more on things that are I've seen quite a bit in public safety. So you see these changes in how people see things over time, which makes a lot of sense, right? So if I'm a police officer or I'm working in corrections, my normal day-to-day isn't people who are having a good day or who, want to show me their new puppy, right? It's dealing with people who are having a horrible time or something very bad is happening. So this kind of filter with which we see the world, if we're not aware of this, can really become kind of skewed over time, right? Because you're seeing threat, you're seeing harm, you're seeing negative, malevolent, bad intent with other people. So you start to say things like, you can't trust people, it's dangerous out there, people want to screw you over, just being more negative than usual, feeling that you can't trust anyone, what's the point? Feeling that you failed at work or at home. And some of this mental filter, it develops because it's adaptive on the job. So if I'm a police officer or I'm a medic and I'm walking down the street and I'm more attuned to perceived threat, right? It's the signs that something bad might be happening or someone might need help. That's very good for me on the job, right? Because then I can respond very quickly and get there and take action. And it's hard to shut that off when we take off our first responder hat and then go home. So this filter that is adaptive for work, if we're not making an effort to try to change that when we go home, it starts to bleed into all the other aspects of your life. Behaviorally, so I'm focusing more about what this might look like in the job here for the purposes of this talk. So if you notice in yourself or your colleague, these kinds of behavior changes, and this is a change for them, they're not usually like this. This might be a sign that something's going on, right? So it's someone who's usually on time, or it's early a lot, is coming in late, calling in sick, presenteeism, so they're there, but they're not really there because they're just not fully cognitively there, and they're just not putting forth their best performance. They might be making more mistakes. When there is downtime, rather than just like chatting with the rest of the platoon, they're just kind of in the corner on their phone, not engaging. Taking on more and more overtime paid duty. And that one sounds a little funny to some people because they're like, if work is so stressful, why do I keep working more? And, often, depression or anxiety doesn't just turn off. So if things are bleeding into home and now you're having more conflict or strain at home, and you don't really want to be there because things feel like they're falling apart, sometimes it's just better to be at work, right? Because at least that's a little more predictable, you know what to expect. Taking longer to arrive at calls, so just not wanting that responsibility, just not wanting to be the first one on scene. Being more argumentative, quick to anger, not calling for backup, taking unnecessary risks. So examples of that I've heard is if you're going to call and you're by yourself, and this is a situation where normally you'd be calling for backup, but you're not. And why is that? Why is this person taking unnecessary risks? So what I've occasionally heard is that it's not that this individual is suicidal necessarily. It's not that they necessarily want to die, but they're kind of feeling stuck and hopeless and they don't really see a way out. So if I get taken out in the line of duty, well, that's honorable and I'm not doing it to myself, right? So it's just, I'm not saying this is a conscious thought process, but this is something that I've heard about and I've seen occasionally where it's just, I'm taking these risks because I just don't care anymore, because if I'm taken out, then good. Other things that you may notice in other people, reduced empathy for others, cynicism, everyone's an asshole, everything is bullshit, there's no good to anything or anyone. And us versus them. Now, some of this is natural and normal for all of us, right? We all like our people in our tribes. And certainly in the PSP world, some of it is normal too, like white shirts versus blue shirts. That's a natural one. Civilians versus uniform. But what I'm talking about here is when it becomes kind of extreme, where no one outside of my circle, whatever that circle is, can relate to me. I can't relate to them. No one can possibly understand me. I don't even want to talk to them. So in some extreme examples, I've worked with some individuals who they were struggling for a very long time, and then they finally went off work. And we would talk about like just activation. Okay, you don't want to talk to anyone from work. That makes sense. Let's get you activated. Let's get you like out there doing something or talking to someone. So who are some other people you can reach out to? And sometimes what I've heard is that over time they've become so centered on their in-group, right? So whether it's their group of medics or group of firefighters or whatnot, that they've gradually stopped talking to other people outside of that profession. So now they really don't feel they have anyone to call on because it's been many years since they spoke to them, right? So that's more of this extreme, this us versus them mentality. All right, so I'll move into treatment. So there are a number of great treatments out there. Of course, what is a bit tricky is that no one thing works for everyone, and people are going to react differently to different types of treatments or medications. So unfortunately, it is often this kind of trial and error until you figure out what's working for you, which of course is not fun for anyone because you're already seeking treatment because you're having a hard time. But there are some treatments that evidence and clinical experience has shown to be more effective for people with depression. So this is coming from the American Psychological Association. These guidelines came out in 2019, and what they really do is they really scour all the research out there because there's so much research it's impossible to keep on top of. But they really looked at all the research out there that's been done on treatment for depression. So what they looked at was overall strength of evidence. What are some of the balance of benefits versus harms or burdens, right? So do the benefits outweigh any risks? A procedure that we've all heard about, which is still done occasionally in some circumstances, but was done a lot more several decades ago, was ECT, electroconvulsive therapy, right? And that could be effective for people with severe depression who weren't responding to anything else. But of course, the risk of harm was significant, right? So it's kind of balancing what are the benefits versus risk of harm. client values and preferences. One example, some individuals, they don't want to try any medication, and that's fine, that's their choice, right? So it's looking at what does that individual client want, and applicability. Is this applicable to this specific individual in this circumstance? Right, so talk therapy, psychotherapy. So in all of their research review, their conclusion was, here are some therapies that have been shown to be effective for depression. Now, there's not one out of these that rise above the rest, right? So really what they're saying is there's a lot of effective talk therapies, and they work in quite different ways, but they have been shown to be quite effective for many people out there with depression. So again, it is really going to depend on the individual and what's a good fit for you. So behavior therapy, this is really focusing on changing one's behavior. So it's also can be referred to as behavioral activation. For example, if I've worked with some individuals who were so depressed, they could not get up and take a shower. They could not get up and brush their teeth, right? So they were so low activated. It's really difficult to try to work on anything else until we can try to get some of these basic steps going. So it's really kind of working on activating them. And in that process, then they start to gain a little more confidence. They get a little more a feeling of efficacy and sometimes pleasure. And then it's a nice feedback, right? CBT, cognitive behavioral therapy, I think probably most of us have heard of this. So it's looking at the relationship between thoughts, emotions, physical reactions, and behaviors, and working on identifying unhelpful thoughts, challenging them, and seeing if we can come up with more balanced thinking. You notice I'm not saying just think positive thoughts, because that is not helpful. It's really looking at how much validity is there in this thought. An example I like to use, it's kind of everyday example, is let's say I'm walking down the street and I see an acquaintance walking in my direction. Let's say Susie. And Susie's a friend of a friend, and I've met her a few times and we had some good chats, but we don't know each other that well. So let's say I'm walking down the street, I see Susie walking towards me, so I smile, I get ready to say hi, and then Susie walks right by me. How am I going to interpret the situation? So one way would be, what the hell? Susie thinks she's too good to me, she can't give me the time of day, who does she think she is? Right? And then I might feel angry. Another way to interpret the situation might be, oh, I guess she doesn't like me, what's wrong with me? Right? And then I might feel sad, insecure. Or I might think, oh, Susan must have a lot on her mind, she didn't even see me. I'll check in on her later, see how she's doing. Right? And you can see the exact same situation, very different thoughts. So it's looking at how interpreting, are there other possible explanations? So that's an example of how CBT can operate. And this is my personal bias, but really I'm a fan of all these therapies that are listed here. I do think they eventually kind of work on changing the same kind of underlying foundations, right? So what do I mean by that? So let's say here are some common beliefs that are seen in individual depression. Might be, I'm a failure, I'm worthless, I'm unlovable, I have no control, everyone will let me down. So let's go with I'm worthless. Now I could come at that from a CBT approach, where it's looking at what are these thoughts that you're thinking. Let's work on looking at the evidence for and against, and let's challenge those thoughts, etc. I could work purely from a behavioral standpoint and get them more activated in things that they find meaningful and that they used to enjoy and get pleasure from, and then as they're engaging in those and doing well at them and engaging with other people, they might start to think, hey, people are liking being around me and this is feeling good, right? And so maybe you're addressing it that way. Interpersonal therapy, where you're really looking at the interpersonal dynamics. If I'm worthless, maybe rooted in a very unhealthy relationship you were in the past, or from childhood, from getting the message from caregivers or peers at school that you're just not a worthwhile person. It may be stemming from that, right? And so if you're working through interpersonal therapy and looking at the interpersonal relationships in your life and working on addressing those, working on improving communication, love languages, etc., then this might be addressing the I'm worthless core belief in a different way, because then you start to get more and more evidence that, hey, maybe I'm not so worthless. So that's my personal bias when I say I do think all of these therapies are good. It's going to be different fit for different people. I do think ultimately you're going to see some of the same changes in the long term. It's just how you go about it is going to be quite different. I will say that I'm a big fan of CBT though. The APA clinical practice guidelines also talks about medication. So they recommend if you want to try medication, the second generation antidepressants. So the two main categories are the SSRIs, and so examples here are fluoxetine, or better known as Prozac, citalopram, Lexapro. SNRIs, so the serotonin and norepinephrine reuptake inhibitors. So it's working on slightly different neurochemical systems. So venlafaxine, for example, is Affective. So again, medication, it's very difficult to predict how someone's going to react. Some will have very bad side effects. Other people will be fine just taking it. So unfortunately, that's a trial and error. But if you did want to try medications, these are the ones that are usually recommended, at least for your first line of medication, the second generation antidepressants. And things you may have heard about or read about, repetitive transcranial stimulation, or TMS. And then there's a lot of exciting research being done with some other substances out there, ketamine, psilocybin, and MDMA. Because research is kind of ongoing, there are research studies coming out now, but it's going to be a bit of time before we have enough peer-reviewed studies and have had enough individuals going through the treatment to be able to say with any definitive evidence that any of these are effective or more effective than some of the standard treatments for depression. So I can't speak to these specifically, but these are certainly showing some promise. And in future years, I think we're going to hear more and more about this. If you want to try things, because I know there's trials out there, the one thing I will always recommend is consulting with a regulated healthcare professional and making sure this is done under the supervision of a regulated healthcare professional, right? So if it's ketamine, it should likely be a medical doctor who is supervising the treatment. So just making sure that there's some protection for yourself. I have seen in my roles working with consulting with organizations, the first responder organization starts, and then they get a little bit of, they get more well known. And then there's all these organizations and individuals coming out and saying, I have this great treatment, I have this great cure, for depression, PTSD, et cetera. But I don't see any protection for the individual, right? Because there's not a lot of research at that point, maybe backing it up. This person may not be a regulated healthcare professional. It's like a physician, psychologist, social worker, registered psychotherapist. And that is very important because that protects you. Because each of us, with our regulating colleges, we have certain standards, ethical guidelines, legislation we have to follow. And very importantly for you, if you feel that any of us who are regulated are acting unprofessionally, unethically, then you can complain to our college and we could potentially get our license revoked. If it's Joe Blow, who's talking to you about trying out this new great treatment, and they're not any of those regulated professionals, you may not have any recourse, right? Because if you say, well, this is garbage, or this made me worse, there's no one to complain to who can investigate that. So just going to emphasize any treatments that you do want to try out, I would just strongly recommend that you always consult with and ideally have the treatment supervised by a regulated healthcare professional. All right, and so moving on to the last section, this is more for the managers and supervisors. Hopefully there are some of you in the audience. And these are not things that are revolutionary. These are not things that you haven't heard before. But I'm coming at this from a few different angles. So the first primarily is as a clinician who has had hundreds and hundreds of public safety personnel in my office, hearing their timeline, hearing their trajectory, hearing their stories, of all the factors that contributed and all the things that could potentially help make things better when they do want to go back. I'm also coming at this from being the chief in the OPP and looking at what what are some of the systemic factors, because I have a different perspective being within an organization. And so what I do really want to emphasize in terms of organizational factors, even if your service has a psychologist or other mental health support, keeping in mind that that's fantastic and that's very necessary. But if the day-to-day isn't changing, that's not going to help, right? So it'll help with having individuals access resources, but do we want people to get to that place in the first place, right? And so I talk a lot about empathic leadership, because this is what really leads to true culture change. And I know this sounds cliche, and I know you've probably heard this 1,000 times, but and I'm talking smaller day-to-day things. I think of a couple of people I've seen in my clinical work, right? And one was telling me, back in his rookie days, there was a very, very difficult call. There was some, there were some coincidences with his personal life, so it's hitting a lot harder. It's very understandable, and does everything he needs to on the call. Then after his part's done, he goes and finds a private space, and he's just composing himself. And then one of his supervisors finds him and says, "What the hell you didn't get back out there?" Right? And then I think of another individual I spoke to who described in his rookie year going with his partner to a very bad, graphic, gory call, and they do what they need to do, and then afterwards his partner's just kind of packing up and looks fine, and this individual is thinking, "Oh my gosh, like, what is happening? Like, this is horrible. I'm having such a hard time, but he's fine. Maybe I'm not cut out for this." And then he was saying how later on in his shift, his supervisor came along and found him and just said, "Hey, yeah, that was just a terrible call, eh? Well, I'm here if you want to talk." These are the kind of interactions I'm talking about. I mean, there's bigger systemic changes that can often need to happen, but I'm also talking about you don't have to just completely flip everything upside down. It's just looking at what are the day-to-day interactions like. How can you just kind of check in and show support without needing to be a clinician or whatnot? So just some things to keep in mind. Also trying to ensure, and I know it's not always possible, but trying to ensure as much as possible adequate rest time, appropriate staffing. If people are getting burnt out and they don't have time to recover, they go into work and now they're shorter fused and they have less gas in their tank, and things are going to hit them harder and harder and harder. So these are some ways that you can try to keep people healthy. Give discretion wherever possible, increase individuals' perceived control. What do I mean by that? So if we go back to one of the organizational stressors being this high level of responsibility, but such low perceived control over a lot of their day-to-day. Anytime you can increase someone's sense of autonomy and control, I think can help with their sense of efficacy. So something I've heard quite a bit, with police officers, and they'll have their shift and they're told they have to get write up this many tickets for the shift, and they're going to get in trouble if they don't write up this many tickets. And there is definitely a need for tickets and enforcement, etc. But if they have a bit of discretion in terms of stopping cars and trying to provide some education and fostering a positive relationship and awareness, which can eventually decrease behaviors, that might be a lot more effective in the long run for some drivers, right? And so just even allowing some discretion there in their day-to-day shift is something that can help increase that sense of autonomy. Wherever possible, consider short-term accommodations. And I know this could potentially be perceived as opening Pandora's box. But instead of, someone says, "Hey, I'm having a hard time, is there any way I can come off the road, even just for a couple sets?" Instead of having to go through go off work and workers' comp and medical notes back and forth, et cetera. If this is something you do have in your power to accommodate temporarily without causing undue hardship to everyone else working, maybe this is something that you can consider. And facilitating access to resources, right? So, clinical supports. I know there's a lot of EFAP, so reminding people they have access to the financial planners there, et cetera. So just helping individuals access resources elsewhere. And one last thing I want to leave off on. So I talked about changes the culture and empathic leadership, etc. And this is for everyone. We're often afraid to ask someone how they're doing or to check in. Why is that? So many different reasons, but it's uncomfortable. We're not used to interacting that way, right? So if I'm at work and I see John, and John is definitely showing some changes, he's coming in late for work a lot, he's withdrawing, he's not talking to people, then what are some ways I can start the conversation? So if I just kind of, sorry about that interruption. So if I go to John and say, hey, I think you're depressed, you may say, no, I'm not. What are you talking about? And then I feel stupid. Or I might say, hey, John, what's wrong with you? And of course, he's probably going to go on the defensive, right? So when you want to check in, it can be less threatening for everyone involved if you describe an observable, right? Something that you can put your finger on. So if we go back to those behavioral changes earlier in the slides, things like coming in late, withdrawing. These are behaviors you can put your finger on, right? So I'm sticking to facts, not interpretations. Hey, John, I noticed you were late twice in your last set of shifts. And when we have downtime, you're usually off in another room on your phone rather than hanging out with us. That's not like you. It's something up, right? And so I'm sticking to the facts, not interpretations. I'm not saying I think you have a drinking problem, you're depressed or whatnot. No, I'm just sticking to the facts. Here's the changes I've noticed. You're opening the door if you want to walk through, right? And I'm trying to make him feel valued and supported. Like, this is not like you, is something up. And he may not walk through that door. He may not be ready to open up, and that's fine, but he knows the door's open. But let's say he does open up. We often think, especially first responders, right? We feel like we have to jump in there and fix it and, get a solution. Ask them what they think might help. So in our heads, we may think, oh my gosh, like, I think you need to talk to your family, and I think you need to talk to your doctor, and I'm going to drive you to your doctor, and we're going to do all this and this. Very well meaning, but maybe in that moment, just what they need is someone to listen, just validate that, yeah, it sounds like you've been hit with a lot lately. What do you think would help? And if you are in a position to help with work accommodations, let them know what's possible, try to assist with the process, and very importantly, follow up. If you open the door, someone walks in, opens up, they're sharing something that they may not have shared with anyone at that point, certainly not with someone they work with. They open up, and you have a great talk, and then you finish with whatever outcome happens, and you leave, and it's never brought up again. How is John going to interpret that? Right? Like, oh God, I just put myself out there, and it's like nothing happened. It's very invalidating. So just some thoughts in terms of how you can start that conversation with someone you work with, or someone in your life, sticking to the facts, the observables, and just asking, trying to go with what they think would be helpful. Great, and that brings me to the end of the discussion. I know I haven't left too much time for questions, but happy to answer any questions or have any chats with anyone.
Perfect. Okay, so and everybody, as I said at the beginning, you can certainly submit questions to the questions box. We do have a few already. If you want to ask your question personally, you can also raise your hand and I will unmute you so you can do that. So the first question I want to ask you here is, does workplace conflict present as an early symptom of depression?
Oh, it certainly can. Again, a bit of chicken and egg, but certainly if I'm depressed and I'm having a hard time and I just have a lower threshold for dealing with things, and I'm not sleeping, and I'm having trouble concentrating, I'm going to be a lot more irritable, or going to be a lot more sensitive perhaps. So certainly if I'm not feeling my greatest, I mean we've all had very bad days, and you can think about how you've reacted to stressors during those days, right? So certainly if someone's experiencing depression or other kinds of difficulties, they may, there can certainly be a lot more workplace conflict that goes on.
So another question, a little bit more personal question here is, recently I wrote some exams for some professional certificates which were important to me. As I wrote the tests and struggled with some of the questions, self-doubt and the loather began to surface from old scars. Was that a form of depression?
I don't know if that's a form of depression in terms of, were you experiencing depression during that time? I think if there's these old scars that are not really fully healed scars, that might make you more vulnerable. So I can't say if you had depression during that time, but certainly, if we have these old wounds that contributed to certain unhelpful beliefs about ourselves or other people, that may make us more vulnerable to getting down, feeling rejected, being extra sensitive to things. So that is something I would encourage you, just for your own well-being and health, to work on with someone if it's something that kind of keeps coming back every once in a while.
Next question is, I was wondering if you could provide a little insight into seasonal affective disorder, how, if at all, it's symptomatically similar to depression, and how people could be aware of it or treat or manage it.
Yeah, so seasonal affective disorder, or MGD with seasonal pattern. So basically it is depression, but it's happening at very specified times of year. So it's usually, winter months like November, December onset, and then remitting or like April, May. And if it's only happening during those time periods each year, and it seems to be coming semi-regularly every year, that's a good indicator that it might be seasonal. And of course, you sometimes have the opposite pattern, right? So some people become depressed when it's warm out in the summer, and then in the winter months, their mood actually lifts. And again, that you'd want to be looking at whether do they get depression at other times of the year? If not, it may be more tied to some seasonal factors.
Any advice to help people who choose to be very reclusive and refuse communication and help, especially when they're struggling deeply? Help offers are refused with anger.
That's a tough one, right? Because you want to help, you want to support, and if it's not helpful, or if you're getting actively rejected, it's tough. What I would recommend, and it's a lot easier said than done, is just continue showing up. And if you know this is not them, they were not like this before, and I really care about this person, and it can be really hurtful, right? But if you keep just even sending that message and just acknowledge, you don't have to respond, I'm just checking in, just thinking of you, right? So the less demand you can place on them, the less burdensome it might feel, right? So if I'm really down and I don't want to talk to anyone, I'm having a really hard time, and someone messages me and says, hey, how you doing? Want to go for a drink? That might be very nice and supportive, but that just makes me feel worse, right? Because now I feel like I'm letting someone down. So if it's more of a nothing here needed, just checking in, I'm here, whatever, just thinking of you, and then they may not respond, and they may not respond for a long time. But I can tell you with so many individuals I've worked with, they've gone months and months, sometimes a couple years without really responding, but they remember. So when they start recovering and getting better, they try to go out and reconnect, and it's going to be much easier and comfortable to reach out if that person has shown, that support during that time. But I will put in a caveat: you do not have to put up with abuse, right? So, if someone says hurtful things, sometimes okay, that's a depression talking, that's one thing. But if every time you're talking to someone, they're actively abusing you and saying very terrible things about you, you may understand where it's coming from, but you also don't have to put up with that.
Can you speak to recovery from depression? What does recovery look like, and is it common?
Oh, so I'll say absolutely it's common. Some people have more chronic episodes of depression throughout their life. So what that means is that they may experience episodes of depression and then recover, and then later on experience depression. Other people, it just might be a one-time or two-time thing. So there's major depressive episodes, right, that count for major depressive disorder. So what does that look like? Everyone's a little bit different because everyone's depression might look a little bit different, but what clinicians often see is, an individual will start to get a little more activated, right? They're feeling a little more energy. They might kind of stick their baby toe in some activities they used to enjoy, like whether it was gym or like meeting up with a friend, or getting some more work done that they've been behind on, right? So, and then with each step, that really helps to empower them to take more steps. So what you see is this gradual increase in energy and activation, and of course mood, and just getting renewed interest or pleasure in things that they used to enjoy, and they kind of lost that for a while.
We have had a few more questions. If you're okay with answering just a couple more, and then we'll be done. Okay. So as one begins to recover, do the neurological changes associated with depression begin to heal up?
I'm sorry, could you repeat that?
As one begins to recover, do the neurological changes associated with depression begin to heal?
So I certainly can't speak definitively to that. I know that there's in the past been studies done where, and again, this is not my area of expertise, so I don't want to say anything incorrect, but you know, when people have done brain scans of someone who has recovered from depression, their brain scans and the structures look similar to someone who's not depressed. So I can't speak to any specific changes or long-lasting changes, but certainly as we're recovering, because you can't divorce our bodies and minds, they're interrelated, right? And so you'll often see improvements in the immune system functioning, in the levels of stress hormones, and I'm guessing likely neurotransmitters, but I can't speak definitively to that.
All right, so last question then is, you shared various examples of how a particular incident can be traumatic for an emergency personnel. I was wondering if there are examples of workplace policies after an incident that do not happen now, but would be useful to incorporate.
So certainly after traumatic incidents, and I can talk a little bit about what we've been implementing within the OPP. So people sometimes talk about debriefs, and you know there's some positives and negatives that people talk about, but I think everyone's using the term a little bit differently. So I'm going to call this basically a wellness check-in. So let's say there's some certain incident that happens, and you know it may be hitting some people quite hard. And then if you have a clinician or trained peer supporter go in and meet with the individuals involved. So not to go over the details of the incident, because if you go through in detail the details of the incident too quickly, that can be traumatizing to some people, right? And what we're doing is we're focusing on reactions, people's responses, right? So giving people a place to just open up and just, you know, realize that they're not the only ones who might be experiencing, I can't stop thinking about it, or, you know, I'm really worried about my kids now, or I haven't been able to sleep in 2 nights. And so just being able to share their reactions and experiences. So just normalizing that, I think, can be very helpful, as well as helping giving some education on what you might expect over the next few weeks or months, right? So it's very normal to have, you know, sleep problems and concentration problems and trouble sleeping, et cetera, for a little while after trauma while you're processing it. So we give that kind of education. And of course, now they're connected with us if they do want to seek more additional individual support. And what is the purpose of all this? It's understanding that all kinds of reactions can be very normal, but we just don't realize that because no one usually talks about that. And what I've seen tripping up people the most, I think, who are in these professions with chronic exposure to trauma is avoidance. And what do I mean by that? Bad thing happened, that's horrible. I don't want to think about it. I don't want to deal with it. So I'm going to keep pushing aside, drinking or keeping busy so I don't have to think about it. But then it keeps coming up. And so the more I avoid it, the more I'm not letting my brain and body process this in a way that's natural and healthy so I can work through it. So I know this is a very long answer to the question, but I really do think being able to provide that space that's clinically facilitated, that gives everyone involved a forum, if they want to come voluntary, to, you know, discuss their reactions, not go into details on the incident, and then just learn some education. And now you've opened up the conversation, so then they're going to feel more comfortable talking to each other after it's all over. Oh, I think you're on mute.
I am. I just realized that. Sorry about that. There was a few questions that we didn't get to, but we do want to wrap up for the day. So thank you, everybody, for your questions. Thank you to Dr. Lee for being here with us today and giving us all this wonderful information. There will be a quick survey at the end of the town hall. We hope that you'll take a moment to complete it. SIPSR does host monthly town halls on topics specific to PSP. If there's something you want to learn more about, let us know in the survey. Next month's town hall will feature Dr. Nick Carlton. He's SIPSR Scientific Director, and he will be here to share research details of his groundbreaking study with the RCMP. A link for this session will be included with the follow-up email you will receive tomorrow. Once again, I want to thank everybody, and thank Dr. Lee especially for being here today. I want everybody to take care and stay safe out there.